Thank you, sir. Sir is my teacher in my PG days. Now you have a lady who wants to become pregnant. She's a PCOS. So first and foremost, how all you approach her. You know that polycystic ovarian syndrome is when the ovaries have small cysts and the body cannot ovulate regularly, and it is one of the leading factors in infertility and can affect the woman's health in many aspects. Like that, she may get GDM, PIH, and all its consequences later. And it's very common. 1 in 10 women, most of them, they have this PCOS. And what happens in this PCOS, as my sir said, there is hormonal imbalance causing excessive production of this testosterone, while negatively affecting the LH and the FH, and resulting in limited egg production, disrupting the women's menstrual cycle. And not only that, and also the fertility is mainly affected. The exact cause is not known, but we can say two causes mainly, maybe genetically. She might have got from a mother, or disrupted signals from the brain of ovaries to the ovaries affect the hormone production. That is, this is nothing but a marker of insulin resistance. When they ask you, say, some cutaneous markers, we have acanthosin like this. This is also a like fatty liver. This is again a feature of insulin resistance. So this consists of rooted and diagnostic criteria. They say the polycystic ovaries, anovulation, and excess androgen. So to start with, insulin resistance causes some hypothalamo-pituitary ovarian abnormality leading to anovulation and also androgen excess. So this insulin resistance, it affects everywhere. Of course, in the liver, it will increase the glucose production, and in the peripheral tissues, it will decrease the glucose utilization, and it will affect the hypothalamo-pituitary axis and cause androgen excess and alteration in the LH and FH, leading to multiple cysts in the ovary and also lipolysis. All this happens and affects the ladies' fertility, and this is mainly why they don't have ovulation. There is an imbalance between this LH and FHS. Usually when the raise is there, we get the ovulation, but constantly the LH is on the higher side and there is no raise at all. There is much imbalance which prevents the release of eggs from the ovaries, and as Sir said, it is a combination of all this. If you say PCOS, they will be obese, they will have insulin resistance, anovulation, hirsutism, androgen excess, all that. They'll have the features of androgen excess like hirsutism, acne, and baldness, and acanthosis, insulin resistant features like acanthosis nigricans. And now you are planning for a pregnancy. First and foremost, you keep in mind that fertility is mainly affected, and in what way, how it is affected. And mainly, this is very common in rural or urban areas. You should think about what are the home remedies you can do to manage, and then come to the medical treatment options. Of course, the insulin sensitizers mainly are metformin and also ovulation inducers. And then, if it fails, you think about some surgical options like ovarian drilling, or if all this fails, you have to think about in vitro fertilization for conception. And if you take the complications, what all can occur because of the PCOS, first and foremost, it affects the menstrual cycles, can cause irregular or absent periods, making the pregnancy more challenging. And women treated with this ovulation inducing agents, they have an increased risk of spontaneous miscarriage, recurrent miscarriage. And during the second half of pregnancy, they have very high blood pressure and go for progress to preeclampsia if not treated, and it will have its potential impact on the baby also. And the other main thing is gestational diabetes. They have some common features, and it is very common to have GDM and PCOS. Usually in pregnancy, the insulin level increases 3 times to overcome the diabetogenic stress caused by the placental hormones, whereas here it increases 7 times to have a healthy baby. And this preterm is more common here. It's more likely due to the incompetent cervix and also high blood pressure over there. And this is especially very serious if they have twins or triplets. You would have seen in the recent WhatsApp that MSOG, she was having preeclampsia and she died. She delivered twins very recently, just 2-3 days back. And now you should help her to prepare for pregnancy. So remember, the joy of becoming a mother is unsurpassable in a woman's life. The journey is as beautiful as the destination, and along the way you discover the women's wonders your body goes through. And PCOS, they tend to believe that their journey is motherhood is going to be more challenging, but don't lose hope. There are numerous solutions existing in the present day to improve this PCOS and smoothen your journey. And first and foremost, she needs a quality prenatal. The simple step first is a must for any woman who wants to get pregnant. When trying to conceive, you should prepare yourself for body fit to conceive in PCOS. This, by early diagnosis and treatment, helps to prevent the long-term complications like infertility, metabolic syndrome, obesity, diabetes, heart disease. Everything can be just by simple lifestyle measures like reducing their weight, and also doing adequate exercise, if not going for okay. So she can overcome all these when she undergoes the lifestyle management, like following reducing her weight if she is obese, and following adequate exercise. Exercise is such a wonderful treatment for PCOS, and if not, you please go for metformin. So how does this PCOS affect the fertility? You know that they ovulate less frequently, and it is difficult for the people to time their sex according to the fertile days of their menstrual cycle. And if ovulation occurs only every few months once, there may be another reason for you taking longer to become pregnant. And with little patience and some lifestyle changes, your PCOS can improve. Your chances of regular ovulation can increase. So please wait. And if you take the pathophysiology again, there is some novel biomarkers involved in the energy and glucose metabolism, which are implicated in the pathophysiology. It's commonly shared by PCOS, GDM, as well as diabetes. They have all have this nesfatin 1, pituin A, kisspeptin, and copeptin. It's common for all these three. And so the international evidence-based guidelines for assessing, first and foremost, if she has PCO, you have to do a 75 grams OGTT first, even if she is a diabetic or not, whatever it may be, she is an insulin-resistant lady, do that first. And if not possible, you do a fasting and glycated hemoglobin. And if the OGTT is negative, you need to repeat in the second and third trimester also. Of course, these ladies, they are also prone for long-term risk like diabetes, heart disease, hypertension, dyslipidemia, endometrial cancer, breast cancer, recurrent pregnancy loss, and ovarian failure after surgery. So you should keep in mind, she is the lady, potential lady to get all this. So keep in mind all this. And how to prevent? It's very easy to prevent this naturally by eating healthy and having a healthy life. Very simple. And stress management is very important here. They should have you should give a assurance, good assurance, and then go for prescribed medicines to keep the hormones in balance and get the fertility procedures done if necessary. So for lifestyle modification, of course, as I said, the behavioral changes, diet control and exercise, and stress management is very important. For menstrual irregularity, you can go for oral contraceptive pills, cyclical progestins, and insulin sensitizers. For hypoandrogenisms, they can have lasers, shaving, topical agents, anti-androgens, cyproterone acetate, spironolactone, flutamide, finasteride, insulin sensitizers again. For infertility, they can go for clomiphene citrate, letrozole, gonadotropin, GnRH analogs, and insulin sensitizers. Of course, we have the latest drugs for reducing obesity now, like our semaglutide, liraglutide, sibutramine, orlistat, and of course, in very high risk cases, you can go for bariatric also. Remember, diet plays a very important role in improving the fertility. This is an anti-inflammatory drug like. Of course, you will all know The diet should consist of whatever we say, that is, it should not be more of carbohydrate. Equally, the carbohydrate and proteins, and the half the plate full of vegetables and greens. This helps in very much in reducing, bringing about the balancing her hormones, and also the bringing down the blood sugar levels, as well as assisting her in losing weight if necessary. And coming to the drugs, metformin is the main thing which controls both the metabolic and glycemic abnormalities, and also corrects the menstrual irregularities. For ovulation, of course, you can go for clomiphene, letrozole, and human menopausal gonadotropin for infertility, and if necessary, you have to go for IUI also. And surgical treatment, of course, we have the laparoscopic ovarian drilling, adhesiolysis, and also you need to treat endometriosis. Metformin, of course, depending on the weight, you have to give 500 milligram, 850 or 1000. That is depending on the insulin resistance, and N-acetylcysteine 600 milligrams, inositol, D0 inositol 600 to 1000, myo-inositol 2 to 4 grams, or combination of this, that is inositol plus folic acid plus N-acetylcysteine, or myo-inositol plus D0. In this, all these are available. But what international evidence-based guidelines says that first and foremost, you can try with metformin alone in PCOS who have a BMI of more than 25. Of course, this will correct all the anthropometric and metabolic outcomes, including the insulin resistance, glucose, and lipid disorders. And even in less BMI also you can try with this. And metformin, of course, it also helps in the later reduction of occurrence of diabetes, 31% in 2 to 8 years follow-up. And N-acetylcysteine, it is an effective adjuvant to clomiphene citrate for ovulation induction, and where clomiphene citrate resistant cases. Inositol again have low level of, the PCOS have low level of inositol. So several studies have shown that the inositol molecule is directly involved in the insulin cellular signaling, and provides improvement in recovery of reproductive abnormalities, decreases the androgen excess, and also improves the insulin level. So she needs a comprehensive management, multidisciplinary approach with patient-centered lifestyle management, metformin to improve her clinical endocrine metabolic features, and also preventing a GDM, diabetes and metabolic syndrome, which are all evidence-based. We have adequate evidence of it, and optimization of our health before conception will prevent the disease in next generations and reduce the intergenerational transmission of disease. Last but not the least, I just want to, my teacher will accept that, do not forget the partner. Even the male partner, he can have the counterpart of this PCOS. If they have a family history of PCOS, he can have infertility. So always test both, investigate both, and come for a conclusion. Thank you.
That was a very fluent presentation.